Okay.
Ahora.
Dear colleagues, ladies and gentlemen, good afternoon. We would also like to welcome you to the second session of this webinar. And we all hope that you have enjoyed the first part. And after all these excellent presentations, you as well as we are planning and looking forward in planning our next reconstruction. Nevertheless, as in all kind of operations, this sometimes comes with a price. And unfortunately, this is all what the second part will be about. It's going to be about getting familiar with all possible minor or major disasters. It's about understanding what went wrong in each case. And it's about knowing all the possible solutions for each and every one of them. And of course, it's about understanding the way to fix them. So I assure you this is as important as knowing the facts about the actual operation. And this session is when I hear all these excellent speakers about managing common disasters in implant-based reconstruction. So now Mrs. Anastasakou will welcome you and introduce the first speaker.
Hello. I would like to thank our audience for being with us on this Saturday afternoon, and especially the very distinguished international panelists, Professor Kumul and Professor Gidioglu and Dr. Soni Sumian for their excellent talks. As Sophocles has mentioned, the era of the nipple sparing mastectomy and the new genetic panels finding new mutations, etc., have risen the challenges in breast surgery. So now I would like to invite Professor Michael Kondos, Professor of Surgery at the Laiko Hospital in University of Athens, to speak about, show us a video about operating the big breast. Thank you.
Hello to everyone. Am I heard?
Yes. Yes, we can hear you.
Fantastic. I have organized, so my talk is about operating the large breast, and we have already heard a few things about it. I have to say this is given within the disasters session of today's webinar. I hope it will not be a disaster. Although sometimes it ends up being a disaster. I have organized my presentation within a video, and I will try to share my screen with you. Yes. Can you see my screen? Yes?
Yes.
Fantastic. So let's start. So I'm about to say a few things about how we do it here in Laiko Hospital, how we do a mastectomy with a reconstruction in one go in large ptotic breasts. I will not be talking all the way. I will make my comments and I will leave you see the video. So I will start by how we do the markings. I repeat, this is a mastectomy with immediate reconstruction in women with breast cancer and large ptotic breasts. I like to mark my patients in an upright position. Sorry. There you go. First, we find the place, the spot of the new nipple, which is done the usual way, which is 21 to 19 centimeters from the sternal notch. And then we try to find, I don't know if you can see my cursor here. Can you see my cursor here?
Yes, we can.
Fantastic. So then I try to find, I mark the 80 centimeters spot, which is 80 centimeters away from the inframammary fold in the midline, in the meridian of the breast. Which means we have two markings on the breast with the patient at an upright position, which is this spot, which is where the place of the new place of the nipple will be, and this spot, which is 8 centimeters from the inframammary fold. Then we draw the lines CD, which are the footprint. C is the most medial point of the breast footprint on the chest wall, and the D is the most lateral part of the footprint of the breast on the chest wall, and we connect these in this way. Now the gray area will be the deepithelialized area. We keep the nipple, of course. And the red interrupted line is a full incision line where the mastectomy will be done through. And this is a typical patient. She's an obese patient with breast cancer. And you can see this relatively recent scar on the breast, which makes things only more difficult. This is the marking size I explained before. And this is the 88 centimeter spot from the inframammary fold of the breast. So you can, and this is the full incision, the full thickness, the full thickness incision through which we'll do the mastectomy. The rest of the area will be the deepithelialized. I'll have to apologize for the video. I don't know if you see it well. We also had some accidents when we were making this video. We had the camera broken, so we had to switch it to an alternative one. I will fast forward the video from time to time. So we all know what I do. First, I demarcate the area which is going to be deepithelialized, and then the area around the nipple, the periphery of the nipple, I should say. This is from a head-top camera. That's why it is moving around a lot. So we have started removing the superficial layers of the skin. You need good assistance. Sometimes in these large breasts, you see that this layer is very weak, so that, and you have to take care so that you don't go into the subcutaneous fat and interrupt the vessels you want to keep. And this is what you end up with. We have deepithelialized all this area. And as you can see, we're going to connect the upper and the lower skin flap. We proceed to mastectomy. This is one of the tricks of the procedure. We do this incision laterally where there are no important vessels for the nipple. As the nipple gets its vascularization, usually from the medial part of the breast, from the arteries under the sternum. we do try to find this fine plane between the breast fat and the skin fat. Not always easy. I have to admit that in obese patients and fat patients, this may be a bit more easier. You see, we have broken our camera now and we've switched to another one. But surgery goes on. And the deeper you go, detaching the breast tissue from the overlying skin, the more difficult it gets because it's in a deep hole. Everything is happening far away from you. We like to use this Teflon diaphragms because we are dealing with a lot of fat and we don't want things to stick on the blade. And now we have moved to the lower part of the breast, to the lower flap, the lower mastectomy flap. You see that I will keep checking with my fingers the thickness of the flap. We all know that. I have to say that this surgery was done without any lights on the ceiling to facilitate the video, to make it better. So we move on detaching the breast from the skin. We also use this lighted retractor, this one here, because it's a long way from where I am to where I work. It's dark in there, so we use this lighted retractor to have to see. And this is the end result. We have detached, sorry, the breast from the overlying skin. And this is what we end up with. So this is the cavity we want to fill with an implant with the breast removed. And then we take special care to the area under the nipple. We do nipple shades and we send off for pathology to make sure that there's nothing left there. They are sent in a separate pot. and this is the area under the nipple. This is what we have left. Then we go on, do the sentinel node biopsy as per routine. This one, this patient had three nodes, all dyed blue. There they are. And we move on to reconstruction. Each one of us has his or her own way of doing reconstruction. Because we have to accommodate a large implant, we have to cut the inferior insertions of pec major, and this is what I do there. So we have to make space for a large implant. And later on, you will see that we will thin out the medial insertion of pec major. So the connection of pec major to the sternum. There you go. And this is what we end up with. The implant will go in there. We use Galaflex at the hospital. I tend to use it for these procedures because it stays where you put it. It's not stretchable. And at least for the first weeks after this procedure, I want it to stay where I have stitched it to. I tend to do the inferior part first. So I stitch it to the inframammary fold because it's difficult to do it the other way around in lateral incision. So I stitch it first and I put the implant later.
Michalis, can I ask you a question?
You can?
Can I ask a question?
Yes, of course.
It's from the audience, actually. And the question is,
Okay.
why use this skin incision instead of a wise pattern? What are the advantages? This is the first question for the audience.
I was going to talk about it later, and the answer very quickly is that wise pattern, this is my experience. I switched to this after wise pattern. Wise pattern has a T-junction, which is the weak point for these patients. We have suffered a lot of ischemia around the T-junction. And wise pattern, we have to exclude all the smokers, the very obese patients, the diabetic patients, etc., etc. While with this procedure, because we keep the vascularization of the nipple from the vessels all around the nipple, 360, we don't cut anything. It is a robust procedure. You will not have any nipple ischemias at all. Or should I say, they are rare, not at all, but very rare.
Thank you very much.
So T-junction for these patients, in my experience, is ischemia, and we try to avoid it. So you see the implant going in, we use tissue expanders, and we do not expand it, the tissue expander, to its full volume until a few weeks later, because we want to minimize the tension exerted on the suture lines.
So another question, whenever you are free and available, is: do you have a limitation as far as the distance from the nipple clavicle distance, where to apply the technique?
No, I don't. Sorry, let me say that this is our third camera because the second camera broke. So this is, you see, there's not such a good quality. So yes, the answer is no. I was going to talk about this later. Practically speaking, there's no limitation to the lift of the nipple because you don't cut any vessels to the nipple. So you see this implant, this expander is so large, it cannot be covered by pec major. I also like Galaflex because I don't, it goes away after some time. I don't care about the small folds here and there because they're all covered. And I can trim the corners if I want.
Michalis, may I ask you,
Yes.
as this is bioresorbable, do you have an ptosis later on?
Corina, I can't really hear you. You're very interrupted.
Do you have any ptosis later on, as this is a bioresorbable mesh?
Do I have any what?
Ptosis later on.
Ptosis.
Sorry. Not really. I'll show you that result. Not really.
Okay.
I have to say, I have been using this one only for a year now. So very long-term results I don't have yet, but up to now, not really. So you see what I'm doing here, and you can see this is the subcutaneous stitches. The tip here is not to put them very close to each other so that you don't struggle the blood supply. So you leave space from the blood to come into the nipple. This scar looks very ugly now, this long horizontal scar, and it's definitely one of the disadvantages of this procedure. But on the other hand, you will be amazed how much it fades out with time. For these patients, we are rewarded by the fact that we can achieve everything in one go. So not two stage, just one stage. We have to replace the expander with an implant. Of course, if one is daring enough, he or she can do it in one step. So I was saying that the advantages of this procedure is that the nipple, this is the end on table result, the nipple preserves blood supply from throughout its periphery. There are only 2 skin flaps sutured along one line, and there's no T-junction. It is feasible, and I think it is very indicated. This is day 7. And this is how the incision, how the scar looks like after 6 months, or actually after a year. We have lifted the other breast, and this is how it looks like. So it's not too bad.
May I ask you another question?
You can?
So it's come from one of the participants.
This is
And the question is if you could minimize the width of the deepitalization or whether that would affect the shape of the reconstruction.
no. So as I say, this is a relatively new technique. We learn as we go. The answer is yes, we can. We cannot make it too short. We can make it look like a bat wing kind of thing, but we cannot make it too short, because if you make it too short, you will not achieve a large, an adequate reduction, skin reduction.
Dr. Kontos,
But you
can I
can.
just...
Now, most recent cases, we make sure that these lines here are not visible in the cleavage, which is good.
Yes.
So the bad result, sorry, I'm showing my bad results now. This is a bad result, you see. This was one of the first patients. She had a good, clean line first, and then you see what happened. And of course, another thing that can happen is ischemia. This is not superficial. This is not superficial. We had to intervene, but usually these cases are done with local anesthetic, and even local anesthetic is not absolutely necessary.
Dr. Kontos, can I ask you something, if it's okay?
Absolutely.
Yeah, Dr. Kontos, I mean, it's a very interesting technique because we use exactly the same thing with a vice pattern. And I do the incision vertically down, and there is no T-junction because you don't create a T on the bottom. What you do is you deepitalize the whole segment and fold it on itself. So technically, the exact technique, the lateral incision, we use it on the medial midline, on below the nipple. And the blood supply of the nipple is circumferentially attached. Exactly the same thing, but it turns onto a vice pattern. That's all it is. So you fold the T-junction on itself. There's no T-junction. It's actually just a vertical incision down. So that's why I did it. Yeah.
Yes, yes, thank you for that. The philosophy, if you want, the philosophy behind this technique is that you usually you want to reduce the skin on the vertical axis. And that is why I chose to do this vertical incision, because you have to shorten the skin. I cannot understand, and can you please explain how you shorten, how you make the skin less with a vertical incision?
No, it depends on each breast how the configuration of breast lies. But commonly, when you can either use a vertical pattern or you can use a vice pattern in trying to do the skin reduction. You draw the design. That's what we usually do. You draw the design, and then the incision goes basically where like you do on the, instead of the lateral, it goes on the vertical segment. That's all it is. That's in my experience. Yeah.
Are there limitations on regarding the degree of reduction you can achieve?
Yes, there are. I mean, if it's a very huge doses, you won't be able to. Yeah, that's the thing.
Okay.
Michali, do you hear me?
Yes, I can hear you.
Okay, it's nice drawing. It's very clever. But why you don't put, in this case, for example, immediately the implant inside? Because as I can see, is a lot of fat remaining back. So with an implant about 300 cc's, you can do it in one stage.
Because we are not brave enough, Dimitris. Because we are not brave enough, and I'll tell you something. We have published this one, and you can see it on PubMed. This technique. The problem, and look what happened. We published it, fantastic results, no complications whatsoever. And after that, we did 2 consecutive patients direct to implant. And with one of the two, both of them had severe complications, and one of them we had to lost the implant. And I think it is because of the tension the implant exerts on the skin and on the nipple. And I'd rather have the luxury, if you want, or the opportunity to suck out water from the implant and reduce the tension if I see that there's any venous congestion or ischemia. I think you're right. With experience, I believe I will be able, or one should be able, to do it all in one go. You're right. You're right.
And another question: have you noticed any fat necrosis on these cases? Because remaining a lot of fat back. So, have you noticed any fat necrosis?
You know what? Sorry, can I do that? Yes. Fat necrosis, no. What we have noticed is this ischemia at the periphery of the nipple. This we have seen. We have seen this, but fat necrosis, no, not really.
Okay, thank you.
It's a very interesting question.
It's
a very interesting point that you raised, actually, because I think in my experience, I feel that leaving fat there sometimes causes, maybe one of the causes of red breast syndrome. People sometimes see red breast, it's probably just a bit of fat necrosis underneath that settles down, rather than actually what we see from the mesh itself, because that's an interesting point that you raised.
Where do I leave fat? There's only a small amount of fat under the skin. There's nothing left there. What I leave is not fat, is the skin without the epidermis. Yes, there's a small amount of fat under it, but the blood supply of this fat is part of the skin, comes from the skin. We talked about actually
not pertaining to your practice in general. That's what because the red breast syndrome is always a question. Sometimes we see the red breast might be due to fat necrosis. Nothing to do with you, Dr. Kontos. It's just general.
No, it's fine. We have seen red breast syndrome with not with Galaflex. I have seen red breast syndrome with other meshes. And usually thin patients with thin flaps.
I think big breast is a subject that we could speak forever, but unfortunately we have to move on. So if we keep some questions for the end, and then we can proceed now with the next presentation from Dr. Kumel. Well, actually, this is one of the original titles we had for the original actual course that we were planning to do. So we kept it as it is, and unfortunately, it's the only thing we kept from the design of the 2-day course we're planning to do with Dr. Kumel here. So it's the cosmetic failure, what went wrong, and how to fix it. I think Dr. Kumel, having all these Master of Disaster course, is the expert to answer that question. So we will be ready to enjoy your speech.
So many thanks for the invitation again. So let's share the screen. I shortened the presentations a little bit to have it. The cosmetic failure, what went wrong and how to fix it. So first, what we called in our hospital jumping breast because the case of animation deformity. So I think we talked a lot about pre and subpectoral, what we are thinking about. And of course, this is a problem of the subpectoral is the jumping breast, the animation deformity. Maybe in the case of a really thin or slim lady, if you look for that one, what has happened because in subcutaneous mastectomy, we have the contraction of the muscle and the absence of elasticity of the lower pole and lifting up together with the implant. And maybe what we did, we published a graduation of that one. What we think that we have 3 grades of that, maybe low grade until a big or large grade to lifting up the nipple areolar complex, what is the most severe adverse events for that patient. Maybe this is a patient's coming to our ambulance and look for that. So this is, of course, what we never want to have. So, and the same, we started just, this is the gradation what we published. First, the grade 1 is the wrinkles, only a small one. and the caudal part, the lower part of the jumping breast. So the second is the conial part, and the grade 3 is if you have this combined and lift up the nipple areolar complex. Just a second, I can't see my slides. Do you see my slides? Yeah.
Not really, no.
No? Oh,
Previously, yes, now no.
okay. Then I probably have to share it again.
Yeah, that's fine.
Okay. So the next we talk a lot about the winkling. Just one comment to jumping breast. The first years we started to cut the nerves, the lateral nerve of the pectoralis muscle, or to cut the muscle. Now sometimes we're thinking about a level change. If it's subpectoral, to change it to prepectoral. If you have, once again, do you see the slides? No.
Now no.
Okay, I'm sorry.
Yeah, that's fine.
So this is what we thinking now, to both option, cutting the muscle or maybe level change to prepectoral. If you have enough space, they have sometimes good results too. The winkling problem, you have seen it. I think the big problem is the bigger size at the end. If you have this winkling problem, maybe the future could be with some ADMs, or maybe what I learned today, Galaflex. I don't know if the winkling is better resolved in that situations for the patients. So the implant rotation, or maybe for that one, or Simastia, only quick and dirty for that one. But we have good results for that one. First of all, we had a lot of sutures to the bones and fix it, and sometimes we screw it, and so it was terrible. What we do now is we do titanium pockets in that case on both sides, and we have good results for that. To take a prepectoral, take pockets, implant reconstruction to solve this maybe unfortunately really bad problem for the patient's severe adverse events after primary implant reconstruction or augmentation. This is what we learned. So that's my last part for that. The implant placement into titanium pocket, the last few cases was really successful to do this on both sides. This is what we learned in the last few months. The implant rotation, I think that we know, all of us, if you do it, maybe capsulectomy, new formation of the pocket, sometimes round implants, because there is not the rotating problem. What we do in Germany, I don't know if it's, we do, in that case, we do polyurethane implants, because they have more fixed capsule and you don't have any rotation problems. If you use polyurethane implants, you have to use it some millimeters smaller from the size that you expected with the normal implants. This is what we learned if you use polyurethane implants, because the size at the end and the size and shaping of the breast is a little bigger that you announce it or measure it. And normally, if you have maybe 13 centimeters, then maybe mostly 12.5 centimeters is the best version of these implants. This is what we experience, only my tips and tricks for these. And afterwards, you don't have implant rotation problems if you use these polyurethane implants. This is what we have. The bottom out, of course, this is the next problem in different situations. Always you have to fix it. I think if it's a strong situation, we fix it on the ribs with non-resorbable sutures. If it's not strong, we're doubling the inframammary fold in that situations, or maybe we talk with the patients with lower weight of the implants, like the B-lines have 30% less weight of the implants. Maybe all these situations, this is what we are doing in the bottom out. We had some companies with screws and so, and I didn't like this, because I think the sutures to the ribs is enough for that one. But not always it's successful. This is my experience too. Despite you have through the bones to the ribs and fix it as you think there's nothing to be, it couldn't be move on the lower part, but sometimes it's despite of any sutures, it's doing in that situation. The next is maybe to retract some of the skins. I think this is my experience. Infections we are talking about, maybe as all this, what we're doing, like we talking our voodoo, what we're doing in the implant primary situations, but in case if we have an infection, we love to use vacuum tapes. First of all, put out the implants, put a vacuum tape, make resistance antibiotics, resistogram, give antibiotics, and if it's free of bugs, then we have good results to have a reimplantation. Maybe years before we had no reimplantation. In that case, is more than 98% get a reimplantation if they want after vacuum tapes. And we changed the vacuum tapes as the is free of bugs in the pocket. So and the results are, in our opinion, are good for that. But sometimes it's a 5 to 7 or 10 day stories for the patients if they have this infection results of the implant reconstruction. So what we are doing for that, since we have maybe the vacuum, there is sometimes with fluid. I only in rare cases I do it, like not vacuum together with fluids, again a pump for that one, because I don't know if it's if you have spaces and caves with fluids and bugs in it. So mostly maybe more than 90% allow only the vacuum tape. Then we have the vacuum tape on the skin. I think this is good. For severe infections, we use the jet lavage because it gets really quick to have the lavage. And because my experience is, as much as fluids as you do it in the surgery, is better all around healing for that one. If you have some other necrosis problems, maybe fat necrosis and so on, maybe tension necrosis of skin or something, we love to have the ultrasound assisted wound cleansing. It prepares a little bit, you see it until it's bleeding. It's not painful for the patients. What we're doing, of course, the antiseptic and antibiotics lavage before we get the implants back. And if we have problems or risk factors, but we have no trials for that one, we start a trial in the next future. What we are doing in our hospital is we do, and this is gentamicin sponge. Maybe after infection, after vacuum tapes and reimplantation, we always use this gentamicin sponge. If we have risk factors, really huge risk factors, and afraid of infections, we use it primary in that situation. And we have, from our feeling, now we have the first results that we have good results, less infections, but not randomized. And we started to investigate it in a trial if the samicin, how it's called in our country, it is a gentamicin-based antibiotic sponge. Many thanks.
Thank you very much for this condensed, excellent speech in 15 minutes. Every complication, every possible complication. Anybody wants to ask questions? Because we don't have, I think from the audience, there are no questions. So anybody from the panel?
Yeah. Would you mind if I just ask a question? I think it's interesting because oh, sorry. Is it okay if I go with the question? Is it all right? Yeah. Dr. Kimmel, Prof. Kimmel, just trying to find out about, we have been using for the last 7 cases of salvage, we have used irrigation, we replaced the exchange implant straight away and put on an irrigation system with vancomycin. For some reason, all the 7 seem to have worked. So do you have have you done a irrigation system as well as a part of your trials of trying different techniques? So?
No, not yet.
Okay.
But maybe the future could be make a try. What if we have, maybe we never did it because we are afraid of that. For me, maybe it could be jet lavage, use the jet lavage and make maybe direct to implant and use antibiotic sponge, because for me, I hated the days in the clinics to change the vacuum tapes, change it. And the next problem, in my personal opinion, of the vacuum tapes, if you have retraction of the skin.
All right.
If you have it after 5 or 10 days, you have the final reconstruction. You have sometimes 20-30% retraction of the skin. You have resected scars again and again. So this is maybe what you are talking. I think that could be interesting. Maybe I feel comfortable if it's not maybe a lot of infections seen, only xeroma, maybe for that one. Maybe using jet lavage, using local antibiotics. We use gentamicin in Germany, mostly because of the good experience of the bone infections.
Oh, yes.
But I think this is equal for that one, and maybe direct to implant. This is for me in the future a way to go for it.
Yeah,
Because
I think it's been quite interesting because we tried different techniques. We didn't have the sponge anyway, but after we started the irrigation technique with the direct implant, it seems to be working. I mean, I've been lucky for the last seven months we did in our unit, but we don't know. It's based on science.
can you send it? Do you have maybe some slides of that?
Yeah, we probably should actually, but we're just auditing the data anyway. That's fine. Thank you.
Thank you.
There's a question from the audience. Does the VAC reduce the pocket volume?
If you put the sponge as the vacuum tape, you have to my feeling is 5 times more sponge than the volume of the pocket, because if you put the vacuum on it, it's shrinkage as much as you can, and so put it as much you can sponge in the pocket, because the vacuum it's closing, and you have to turn on the vacuum. You have maybe a 30% shrinkage of that one.
Okay, thank you
And
very
for me,
much.
the shrinkage this is a problem for me. The shrinkage because of the vacuum situation of the skin.
But it's always less than leaving it without a vacuum, isn't it? I mean, if you just leave the cavity to close up and then do it again, it's going to be much bigger the shrinkage than it is with a vacuum, isn't it?
Yeah. So.
I think so.
But maybe at the end, we are happy that we have the vacuum system. On the other side, maybe in former times was not possible to have a reimplantation. So most of the patients get a reimplantation. I think this is successful for most of the patients, but maybe develop it further. And the jet lavage, we have this from our trauma surgeons. If they have big bone lesions and they have problems with infections, they said the jet lavage is nice. So maybe that could be, and they told us maybe these are a lot of liters, 4, 5, 6 liters you are going away that, and they told us this is the best situation maybe for problems with infections and cavities. Maybe let's look for it.
Thank you very much. Corina?
Yes, so thank you very much. I would like to invite Dr. Andreas Ravanis, who is the Director of Plastic and Reconstructive Surgery at the Metropolitan Hospital, and he will speak about tertiary breast reconstruction following major disaster. Dr. Ravanis. You have to unmute. We can't hear you. You have to unmute.
So right now, thank you.
Yes.
So good afternoon. I would like to thank the organizing committee and Mr. Venizelos for the very kind invitation. So I have to talk to you about major disasters. And before talk about major disasters, just 1 second. Actually, I cannot advance my presentation. So before talk about major disasters, I would like to share with you the official statistics published by the American Society of Plastic Surgeons in 2018 about reconstructive breast procedures. And as we can see, more than 100,000 breast reconstructive procedures took place, with the vast majority to be implant-based reconstructions, about 83,000. There was a significant decrease in the use of pedicle flaps, less than 6,000. There was a decrease about 40% as compared with the statistics 3 years ago, probably recognizing the significant morbidity that the latissimus dorsi muscle harvesting and the rectus abdominis muscle harvesting is associated with. But on the other hand, we had a significant increase in free perforator flaps in the use of for breast reconstruction, and there was an increase about 30%. But I would say that the most interesting statistic is the last one, that 19,000 breast implants had to be removed. That accounts about for the 25% in the same year. So how to define a major disaster? Probably it's a serious implant infection that not responds to the antibiotics. Implant extrusion, probably due to the poor blood supply, due to the radiotherapy, or to the excessive pressure from the implant. Skin necrosis and major skin necrosis, probably due to a poor surgical technique or to poor preoperative design. Unfortunately, the most of the cases will result to removal of the implant and failure of the reconstruction, and unfortunately to a very serious disfigurement of the patient. But talking about major disasters, what I have came across with 3 or 4 times was simultaneous serious implant infection and synthetic mesh infection that it's very difficult to deal with, and the cornerstone of the treatment is to debride all the infected tissue, unfortunately associated with the overlying skin that is very adhered usually to the synthetic mesh. Apart from the reconstructive disasters, we have just reconstruction failure, poor cosmetic outcome, or poor symmetry with the contralateral breast, or just a severe capsular contracture. This is a very interesting meta-analysis that was published last year and is investigating 26 published studies. And from this meta-analysis, it was evident that the pooled rate of implant reconstruction failure and need for flaps was 19%, ranging from 10 to 29% in the cases that we had pre-reconstruction radiation therapy, and similarly 20% when we had post-reconstruction radiation therapy, ranging from study to study from 15 to 25%. In 2013 was this paper published and defined the tertiary breast reconstruction as a salvage procedure of a previous breast reconstruction in case of patients with inflammation or implant exposure, patients with failed breast reconstruction, and patients with unsatisfactory results. Mustafa Hamdi published in 2011, and he stated that the tertiary reconstructions involve the reconstructive outcome, capsular contracture grade 4, and the patient's desire for normal. The treatment is removed for all scar and or inflammation tissue, restore the footprint, the conus, and the skin envelope of the breast, and according to authors' experience, DF flap is the most commonly used. So 2 years ago, we did a retrospective study of our cases aiming to identify the reasons of the unsatisfactory result and to record the results of the tertiary microsurgical breast reconstruction. So we did a retrospective review of all our patients who underwent revisional breast reconstruction with autologous microsurgical tissue between 2013 and 2018 in a period of 5 years. So our study revealed 67 patients. 41 out of 67 patients had implant-based reconstruction, whilst 22 presented to us with already failed prosthetic reconstructions due to implant exposure or infection. 4 were oncoplastic procedures and post-op radiation that resulted in a significant disfigurement of the breast, and 1 case was unsuccessful latissimus dorsi flap reconstruction. 59 patients had received radiotherapy in our series. 50 patients presented with capsular contracture of grade 4, and the mean BMI of our population was 32. 41 implant-based reconstruction patients reported physical discomfort and paradoxal breast movements, asymmetry and cold sensation, and 41 patients reported persistent pain. And actually, what we found when we removed the implant was serious depressure of the thoracic cavity and the ribs. All microsurgical breast reconstructions in the 67 patients were successful. The postoperative course was uneventful without complications, and the mean hospital stays was 4 days. The unilateral DF flap was the most harvested in 52 patients. We have used bilateral DFs in 3 patients. As an example, I will report you this particular very complex breast patient. She was obese, she was a heavy smoker, she had radiation on both breasts, she had 8 previous attempts for any type of reconstruction, she had exposure infection finally of the one implant and capsular contracture grade 4 to the other implant. And the most serious thing about her history was the pulmonary embolism due to the course of the chemotherapy. So difficult decision to get with this difficult patient. The CT angiography revealed very good perforators on both sides. So we went ahead with a single stage operation to reconstruct the patient. And this is the final result with the bilateral TAPs. Probably not the most symmetric outcome, but with a single stage operation, we gave her back both breasts and a normal body status. We have used a free profound artery perforator flap, PAP flap in 5 patients, and transverse upper gracilis in 4 patients. Combination of DIEP and PAP flap received DIEP flap on the one side and the PAP flap to the other side in 3 patients. So regarding the symmetry, this was achievable in the majority of the patients in one stage with the aid of CAD/CAM technology, but 22 out of 67 patients underwent to further symmetrization procedures. For example, this young patient, she had a contralateral breast augmentation, and actually it's very difficult to differentiate her from a non-mastectomized woman. Lipofilling is also always a very useful tool in our hands for a second stage to increase the volume and projection of the flap and give more symmetry. In Metropolitan Hospital, we have developed the last 3 years a 3 medical imaging and printing lab consisting of a 3D photo scanner by Canfield, the Vectra XT. We have also a portable Vectra X2 for the operating theater. We have 5 different 3D printers. So by using the commercial 3D scanner, we can estimate the difference in volume between the 2 breasts. We can print the models either from the scanner, from the photo scanner, or from the chest and abdominal CT. So we can get 3D rapid prototyping models of the mastectomized chest, the healthy breast mirror image, and the abdominal flap. These models can get sterilized and can be used intraoperatively as sizers to facilitate symmetry in one stage. For example, this patient, she got a DIEP flap and at the same stage, a small reduction on the right side, and you can see she could get a reasonable symmetry in terms of volume, just a difference of 12 cc. Even the most challenging reconstructive cases, as is this patient, you see the big difference. You can see the major disaster here. Print the rapid prototyping models, mastectomized breast, breast mirror, abdominal flap, use them intraoperatively. On your right-hand side, you can see a very simple method, an ancient Greek method, how to estimate the volume of the flap by raising the level of the saline water. And you can see the early result of this disaster, the late result, and the difference is just 9 cc's in this patient in the volumetric analysis. And what I like to do sometimes is to just take some photos of the patients in a relaxing position, so to see how the flap moves, how the breast behaves, and you can see in these positions how the reconstructed tertiary reconstruction looks like, and how, on the other hand, on the other side, the patient, she had direct to implant reconstruction in a prophylactic mastectomy. So retrospectively, we try to identify the risk factors for a major disaster. Actually, in our series, the preoperative design and the technique was not a statistically significant risk factor, surprisingly. But on the other hand, radiotherapy was a statistically significant factor, as well as obesity and high BMI. So, as a conclusion in this retrospective study, physical discomfort, asymmetry, persistent pain, but mainly inflammation or implant exposure are the main factors that lead the patients to revision or operation. Although it's very well documented the superiority of the immediate breast reconstruction as compared to secondary or tertiary breast reconstruction, I think that microsurgical autologous flap transfer performed by a specialized surgical team is still the gold standard and can still result in a breast that looks like a breast. The woman feels like a breast and behaves like a breast with a normal ptosis in the progress of time. And it is the greatest satisfaction for the reconstruction team to see patients that they had tertiary breast reconstruction to be confident enough with their body to expose the body in the social media and carry on with a normal life, leaving behind the mastectomy, leaving behind the failure. Thank you very much.
Thank you very much, Dr. Gravanis. Are there any questions from the panel? I don't see questions from the audience. So may I ask you, please? We're talking about surgical disaster, but do you have cases where a woman comes with symptoms of, I don't speak about the lymphoma, rheumatic disorders or autoimmune disorders, which could be caused by the implants, because you have a hazard ratio of 1.2, so you have a 20% increase for rheumatic disease. Do you experience any such cases?
Actually, regularly we consult patients that they are opponents to implant reconstruction. Either they had somebody from their environment, they had a bad experience with the implant. Regarding autoimmune disease, actually, it is not proved that the implants may trigger these diseases, but there are a lot of patients that are consulted by the rheumatologists, and they do not support the implant-based reconstruction.
Okay.
Dr. Gravanis, can I ask something if you don't mind? Out of the percentage of patients, out of the 60 so some numbers patients you've done, how much percentage of them were PAP flaps and how many of them were tugs? Just for my curiosity to know the numbers that are being done.
I saw the numbers. I think that we had 67 patients in total that they had to do tertiary breast reconstruction. The 52 were DIEPs, four PAPs and 5 tags, something like that. But generally, even the official statistics, I would say that the 90% is DIEP flap. Only if the DIEP flap is not available, then we'll go for a different flap. PAP and tag flap that are almost similar. Actually, PAP flap is to tag whatever is the DIEP to the tram flap. I mean, you don't use the flap, the muscle, sorry. Has very good result only to immediate reconstructions, because you cannot reconstruct the skin envelope in the same way that you can do with the DIEP flap.
Thank you.
Dr. Antonopoulos.
Hello. Andreas, congratulations about this presentation. No questions, just a comment from the point of view of plastic surgery. We are plastic surgeons. We don't forget that the big increasing of the breast reconstructions the last decade is due of using implants.
Sure.
The second is that this type of surgery, I do microsurgery, and I have a lot of experience, as you know, and you do as well. It's done by the very, very experienced surgeons. The DTI technique, the implant-based and the implants, they are not using all the time by experienced breast surgeons. So we see more complications. On the other side, working in a private sector, I had the experience working in the hospital, now in private sector. It's very difficult for the patient to be happy when we say, okay, the best result is going to be using autologous tissue. So the cost is another question as well. My opinion is that the implant-based and the implants are something like white and black. They are not. There is no a gray zone in the middle. And on the other side, using the implants, it's very individualized technique and by the special by the special plastic breast surgeon, which this breast surgeon must have the experience of the reconstruction and the philosophy of the reconstruction. Okay, this is our comment through my experience.
Actually, I mean, I have also the same opinion. I mean, the fact that the 80% of breast reconstructions worldwide are performed with implants, it means something. The implant-based reconstruction is a simple reconstruction, easily available everywhere from everyone, and you don't need special skills and teaching as you need in microsurgery. But my talk was about tertiary breast reconstruction in complex cases. But from my point of view, from my opinion, and actually the last 2 years, there are so many papers that evaluated with breast-Q the outcomes comparing autologous reconstruction with implant-based reconstruction. The patients support the autologous breast reconstruction. Is a reconstruction a lifetime reconstruction? The implants are not a lifetime reconstruction. But
yeah, I agree.
We don't have.
I think I will have to interrupt you now because we're going to a completely different discussion now.
The plastic surgery.
As Dr. Gravani said, 80% are done or 90% implant-based reconstruction. That's what we're talking about. Obviously, tertiary reconstruction would be done with autologous tissue, and I think we all agree on that.
I would like to pass a message. If you have a major complication, don't delay the patient and refer to a patient to a microsurgical unit.
I think this is a very good message. I think that should
don't delay him with any treatment.
And another message for me is the implant-based reconstruction seems to be simple, but personally I find it very, very, very difficult. Sometimes more difficult doing a DF flap because the patient is different. So it's not simple. This is my message for the audience and the breast surgeons. It seems simple, but it's very difficult.
From the technical point of view, it's simple, but it's very difficult to have a good result. It depends on the method. It's the method. It's very good to get a good result with the flap. It will become better and better in the progress of time. But
can I just add something? I think we all acknowledge that I think autologous breast reconstruction is the gold standard. I think there is no doubt about that. Unfortunately, when it comes to assessments and when patients go through a cancer pathway, a lot of times they make the decision, though we offer DFs to them, sometimes they can't have the time to actually comprehend and make a decision. So a lot of times we tell patients, but patients should have a fair choice. And I think we all agree that autologous is the gold standard, yes.
Actually, we don't have the resources to do free flap in every patient. There are too many patients to do.
So thank you very much for all this constructive discussion. And then we'll move to the next speech. We know that in the early 90s, we started doing all these nice skin-sparing mastectomies. Then in 2000, we picked up the nipple-sparing mastectomies. And we know that the more skin we preserve, the more the complications. So right now, Dr. Yanaz is going to speak about all these disastrous complications coming with these minimal invasive mastectomies. Could you share the screen with us?
I'm trying to share the screen. Sorry.
Okay.
I don't know why.
So to say, Dr. Yanaz is the director of the Plastic and Reconstructive Unit of the Euroclinic Hospital. Just stalling until you open up your screen. Okay then.
Is it okay now?
Είμαι ο τεχνικός και γενιά με ακούτε.
Ναι, σ' ακούω.
Πρέπει πρώτα να ανοίξετε, να βγείτε από το share screen τώρα, να ανοίξετε πρώτα την παρουσίασή σας.
Την έχω minimize την παρουσία.
Ναι, πού είναι.
Εκεί.
Ωραία. Την επιλέξετε γιατί την κάνετε share.
Οκ. Share, μα τώρα δεν έχω το... Οκ.
Δεν κάνετε minimize τώρα αυτή. Είναι ανοιχτή, δεν κάνετε minimize. Ανοίξτε το share του υπολογιστή σας και θα τη δείτε σαν πρόγραμμα.
Τώρα μπορείτε να τη δείτε.
Ναι, άμα την κάνετε full screen θα τη δούμε.
Full screen, ok.
Για να δούμε. Πολύ ωραία. Εντάξει.
Okay, thanks. Good afternoon, everybody. I will give you a brief overview of the skin and nipple necrosis complications. And also, as you realize, I'm a plastic surgeon. So we are called upon to help on problems and disasters that may result following nipple sparing mastectomies. As you heard from the previous speakers, there's an increased rate of nipple sparing mastectomies over the last 10-15 years. And there's no doubt that these procedures are necessary, and several studies demonstrated the potential for improved aesthetic outcomes, the potential for improved health-related quality of life for these women. And these studies have demonstrated significant psychosocial and sexual well-being for these women. I will just a brief overview of the anatomy, although has been mentioned earlier. Just remind that the perfusion for the nipple necrosis and for the skin flaps is mainly by the internal thoracic artery, with contributions from the lateral thoracic artery, the thoracoacromial artery, the anterior intercostal arteries, and the subdermal plexus, which is random blood supply. And it is an important plexus we have to maintain on the subcutaneous mastectomy. Following mastectomy, subcutaneous mastectomy, effectively the skin flaps and the nipple have random blood supply. And that's why the subdermal plexus is very important for the preservation of the nipple perfusion. And also it is important to maintain minimally 1 centimeter thickness on the skin flap. Now, it was mentioned earlier the lamina superficialis, but this, which is an anatomic boundary, but it's very difficult to identify on the dissection. So I would advise roughly to keep about 1 centimeter as a minimum thickness on the flap. Different causes for the skin nipple necrosis, which reduce the blood supply in a different way. First of all is the smoking, which would decrease the blood supply in about 15% of the skin flaps and the nipple areola complex. The incision, for example, the incision on the intramammary fold would decrease the blood supply about 17%. The mean arterial pressure would, for every 5 milligrams decrease, will cause 1.5 decrease on the blood perfusion. The breast weight has effect. The breast weight of the mastectomy has effect on the proportionally on the blood supply. As the operative time, the retraction injury, which we should never forget, because it causes a lot of problems, especially on the areas when you try to do a left subcutaneous mastectomy for a right-handed surgeon. There are studies that demonstrate that for a right-handed surgeon, it's more risky to do a left subcutaneous mastectomy. And also the body mass index, which is not an independent predictor of skin nipple necrosis, but as we know, increases the risk of complications in this operation. Now, what is the best incision? There are different incisions, and we've seen a lot of options while during the previous presentations. But generally speaking, the incision, the IMF fold, the radial lateral incision, and then there are different variations of the periareola or partially areolar incisions, or the vertical radial incision. There's several studies now that indicate that the IMF fold and the lateral radial incision are the most commonly used because they are the two safest incisions. And there's definitely lower rates of necrosis compared with the other incisions. There's a very nice study back in 2018 on the PRS, Plastic Reconstructive Surgery Journal, which compares the two incisions and actually eventually showed that there's no significant difference when all the covariates taken into consideration. And they did studies with fluorescent to indicate that, to demonstrate the perfusion, and with Doppler. And what we know, that's the IMF fold incision would spare the blood supply from the internal thoracic artery, which, if you remember, it's what we need really to maintain the blood supply to the nipple areola complex. It may disrupt the vascular zone anterior to the inferior border of the pectoralis major muscle, because it's where we place the incision, is the in the IMF fold in the lower, on the lateral half of the IMF fold. And it is more difficult to do the mastectomy in the large breast. This is technically more challenging, but it's worth the time. In several studies, there was a demonstration that the IMF incision has the fewer complications. In the lateral radial incision is another safe incision. It gives us the opportunity to perform the mastectomy much easier. It has a similar decrease in perfusion in terms of the nipple areola complex, so it's quite safe. And there's no difference with the IMF when adjusting for covariates. Now, when we do a direct implant reconstruction, we should never forget that the implant placement by itself reduces the perfusion to the blood supply to the skin up to 40%, depending on the volume of the implant. So the larger the implant, the more will be the effect on the perfusion. We should never forget that. You can achieve very nice reconstructions, but you can have major disasters following these operations if you forget that the implant would cause pressure to the skin. Tissue expander has much less effect. It is safer, and that's why until now we used to do more breast reconstruction stage with tissue expanders. There's no doubt about that. Regardless of the cause that would reduce the perfusion to the skin, if we go down to about 11–12%, definitely that will lead to some sort of necrosis and a major disaster. A disaster like that, and you've seen photographs earlier by my colleagues, it is difficult to manage. And the question is it full thickness? Is it superficial? Is there a muscle cover underneath? Is an implant or a tissue expander? Different questions and then different answers to each one. But definitely what I would say is that if there's muscle cover under a skin necrosis like that, you have the chance to salvage the reconstruction, because you will debride it, the implant will be well covered by the muscle, and you will achieve healing very quickly, and you will have a intact implant and breast, as in this woman that had a latissimus dorsi flap. Generally speaking, these cases should manage with clinical observation if you have a dry scar. And if there's no signs of infection and it is a superficial necrosis, then you could wait as long as you want. If though there is a full thickness skin necrosis and there are signs of infection, you should debride. You should do aggressive debridement. If there's muscle coverage of the implant, then there's a good chance that you will salvage the implant, and you should attempt to salvage it. If the implant is exposed, there's no point wasting your time. You should remove the implant. You should allow the breast to heal, and then do a secondary or tertiary reconstruction at a later stage. Otherwise, you have a patient that goes back and forth trying to salvage something that is not salvageable. Attempts, and we have to keep in mind that attempts to salvage the reconstruction is more successful if there's an expander rather than an implant, because you can adjust the volume of the expander and you can take the pressure of the skin flaps. Now, as a conclusion, there's no doubt that this is a very serious complication. It is difficult to manage. Surgical technique is always important, because a lot of it depends on how much thickness you're going to leave on your skin flap, how much you're going to damage your subdermal plexus when you do the subcutaneous mastectomy, how much your retractor will damage the skin, the perfusion to the skin. The skin incision selection is important, and also the smoking, which is an independent factor. So all patients should be asked to quit smoking before the operation. In any case, none of these individual factors should be underestimated, and we should always keep reminding to our anesthetist that they say maintain a good blood pressure and oxygenation intraoperatively and postoperatively, because that can be the tipping point of going on a skin necrosis rather than on the other way. Thank you very much.
Thank you very much, Dr. Yanas. Many things to think about. And are there any questions from the panel?
May I ask a question? Is it interesting? Very good presentation. Very interesting one, actually. One thing I just want to ask you: on any occasion, have you used any sort of local perforated flaps to cover the defects from where the skin necrosis is? If, like, for example, we have used sometimes we have to use a limbo flap, or sometimes a rotation advancement flap sort of thing from the inframammary fold, or from lateral using a light cap to actually cover the defect. Have you sort of done anything on those lines to salvage?
Thank you for the question. Again, going back, if there is an expander and there's a good muscle coverage, then I would attempt to salvage it with a perforated flap or somewhere from either as a tap flap, either as a flap, random part of flap from the lateral thoracic wall or from the upper abdomen. If the implant is exposed, I wouldn't attempt to do that. I would remove the implant, I would bite the bullet, I will allow it to heal, and then go and do a secondary breast reconstruction. I find it many times that it's a waste of time keeping on bringing back the patient to try to salvage something that is not salvageable.
It's interesting. I think I'm sorry to say, I slightly beg to differ on that, because that is what we were all taught through the years when I was training as well. But over the course of time, I think we've slowly learned that there are times that I tell the patient that we will give one shot at salvage. And we have used, primary closure, put an expander back, and even if the implant is exposed, use the irrigation system. Seems to have worked in some cases, but you're right. It's very hard to judge and actually sort of predict what can happen. Really. Thank you.
There is also, a question from the audience. So for please to you, which concerns the largest volume, implant volume, where you would suggest a direct implant reconstruction. I don't know if you hear me.
Yeah, I can hear you. I mean, the larger the implant, if you do a direct implant reconstruction, the larger the implant, the more risky it is to the skin and to the nipple blood supply. So you will have to be very brave to put a larger implant than what you removed, because you will inevitably cause some damage to the perfusion of the skin and the nipple. So I would be very careful on using large implants. A lot of it, going back to what Dr. Sunil was saying about trying to salvage, has to do as well as if you work in the independent private sector, it is very difficult to continue, bringing the patient back and doing continuous lavage or trying risky things. It's a very different thing if you practice to a big NHS hospital or a big university hospital. So the background as well on that is important. It has to be taken into consideration.
Fully agree, yeah.
I think the question from the audience had to do with the largest, not putting a larger implant, but which would be the largest breast volume in which you would perhaps go for a direct implant reconstruction. How big a breast?
Well, I mean, that depends on other covariates as well. It's not really an independent, that's just the size. It wouldn't make me reject or approve a patient for a direct to implant reconstruction. There are other factors. Was the quality of the skin? Was the quality of the tissues? How old is the patient? Has any other comorbidities? Is she a smoker? And so it's not an independent factor. So if even a large breast, let's say 700 or 800 grams, it would be qualify for a large direct implant reconstruction if all the other factors are there.
That's an excellent answer, actually. And let's keep in mind that the bigger the implant, the bigger the risk. This is what you said initially, and this is what counts. Absolutely. I think Dr. Kondos wants to make a last question because we have to move on. So, Mr. Kondos.
It's not an actual question. Thank you. It's not an actual question, but I need to highlight something. I think that the decision of whether to do something very interventional or watch and wait after nipple necrosis is very personalized. And on top of that, we have to put in the mix that the element of chemotherapy or of adjuvant treatment. Many of these patients will need to have adjuvant treatment, and we cannot waste a lot of time dealing with complications and delay the adjuvant treatment. So I think it's a difficult decision that depends on many factors, and chemotherapy perhaps is the most significant because it affects survival.
That's a good comment. I think, Dr. Antonopoulos, can we keep some questions for the end, because Dr. Kumel, we have kept him here for ages, and I think he's really keen into moving to his presentation, and maybe give us a comment about this last subject.
I have some interesting comments about the large implants.
Yeah, but let's keep it for the end if we can.
Yeah, okay.
So, Corina.
Then we will then proceed to our last presentation again by Professor Kummer. It has been a very big day. So it concerns the diagnosis and management of post-radiotherapy complications. Thank you, Professor Kummer.
So many thanks for the last presentations. What I did in the meantime, I hide a lot of slides because we are talking a lot of problems, only the two aspects. Maybe to mention what happened, because we're talking about autolog tissue and implants and so on, and then we have time to maybe to discuss at the end about large or big implants and so on. So the diagnosis and management of radiotherapy complications. First of all, I think it's always the questions again. What we're talking in the future, it's pre or subpectoral, better maybe if we know what's happened for that one. And if we realize where we are coming from, if we know before, maybe if we have a biopsy, we know that it's a high-risk patient because we have to use a chemotherapy. Probably a lot of colleagues said, yes, this is a primary situation of mastectomy, and maybe afterwards radiation, then maybe the reconstructions. I'm always talking is, please aware, the patient has breast cancer, no skin cancer, and we have to deal to relieve as much as skin as possible for that one, because my personal opinion is as much we can relieve from the skin. I think the cosmesis at the end is always the best shaping if you have the natural skin, maybe, and preserve the nipple areolar complex. So please look at the data, what we have for that one. First of all, what we're thinking is that prepectoral is bad because of capsular fibrosis, because as an implant, maybe, and afterwards radiations. What we are talking to our patients is if we know before the surgery that we have a direct, we always use direct to implant reconstruction mostly when we talk to the patients. If we know there's a maybe indication for radiation therapy, we talk to them to say, yes, the implant, we think it could be a placeholder. Maybe in some cases we can, we don't have to change it to autolog tissue in that situations. Let's look at the literature. And I was surprised if you look at the literature. If you summarize the capsular fibrosis, there was no signal from the last literature from the United States, from the Yale New Haven Hospital, pre versus subpectoral, no signs of more capsular fibrosis in case of prepectoral placement of the implant. And the Baker grading of the implants was not more pronounced in a prepectoral situation. So I think this was a little bit surprising. If we go for the literature, but these are all the publications, and you see this actual meta-analysis from 2019 published said maybe you see that subpectoral has less problems after radiation in case of capsular fibrosis for that one. But maybe be aware of that. Always we are looking for trial. We don't have randomized trials for that one. Always we are looking for that one. These are not primary endpoints. This is not fixed in CIFs and so on. It's how we know how individual is it to look for capsular fibrosis if some maybe students going to the reports of the walls and so on. I think this is a problem of all the literature what we have for this problem, maybe to have a good algorithm for that patient to preserve the skin. If we know, this is the most critical point, if we know before that the radiation of post-mastectomy is coming. So this is of our German guidelines algorithm. So of course, maybe talk with the patients about the concerns and complications rates. We have to talk about more than 40%. But in my personal experience, a lot of patients decide for the direct to implant reconstruction, beside they know that 40% complication rate if the radiation is coming afterwards. And of course, first choice is autologous tissue. That all we know. That's why I hide in all the other slides for that one. The timing of the implant-based reconstruction in case of radiotherapy, I think we have more and more data, and we do it before the radiation therapy is coming. So, and mostly as a direct implant situations. As our personal experience, and maybe in 2010 to 13, we always did it with tissue expanders because we had the feeling if the radiation is coming and we have some side effects, please be aware, less volume, better feeling for the patients. But our experience, and we published it, we had as 8% higher complications rates in the usage of tissue expander because of the harder edges of the expanders if you have less volume, and we didn't have better capsular control under radiotherapy if we have less volume of that situation. So this was our experience. That's why we changed mostly to preserve the skin and the direct to implant reconstructions before radiotherapy. And at the end of the story, maybe if the capsular contraction is coming and the patient's decided for microsurgery or maybe a flap surgery in that situations, I think for me, it's the same to put out the implant or the expander to change it to autologous tissue. But the breast, if you know, maybe for the microsurgeons, you see if you have the envelope of the natural breast, I think it looks very well if you put the deep flip under this one for the patients at the end. No one is seeing most of these side effects what we saw in the pictures before. Special cases, that's why at the end of my talk, what is doing if we can't do a flap for that situation, this is a bilateral subcutaneous mastectomy with axillary dissections. We know it before. This was a huge axillary involvement of suspicious lymph nodes 11 days after post-surgery, a little bit asymmetry because of the different envelope of the breast tissue. Look for that, and then radiation starts and you see the shrinkage, maybe as early as we wanted to have for that one. And at the end of the story, yes, this is maybe the feeling was okay. The capsular fibrosis was grade 2 through 3. The IMF is going to the upper pole, and we have a deficit of the volume, of course. And now we had the problem. We said, yes, maybe it is a good choice for autologous tissue reconstruction. We had enough, maybe fatty tissue for that one, but the patient said, no, I want to be pregnant in the next few days because my cancer is more than 2 years ago. I want to have this. So we had no choice. So our decision was a lot of discussions. Do we do autologous lipotransfer, like lipofilling, because of afterwards the deep is really dangerous for the microsurgeons if you have the liposuction before in that situations. But he said, okay, we do this because the patient said, no, to be pregnant is one of the most important point for her, and we did the lipofilling in that case for her, and these are the results at the end, and the patient was satisfied. What we're doing is the Coleman method with centrifugation, and we do the body jet system. This is the water injected system for the liposuction. The patient was satisfied, and what we're feeling in that case is that the patient has not such pain afterwards. So I know maybe if you have a better fatty tissue in surrounding situations, of course it's better from the feeling for the patients, but we realized, or maybe the patient told us, the pain of the capsular fibrosis was a little bit less after this procedure. So this was a side effect maybe of the maybe reconvalescence, or maybe of this fatty tissue. I think this is an aspect what we have to deal with in the future. So this is after all the months and years the case for that one, and she was happy with liposuction and autologous lipotransfer in that case. So we can spare the flap. Actually, that would be the first choice beside of the wish to be pregnant afterwards. This last case is what we did sometimes is it's coming after maybe the specialized radiation situations. If you have an one-shot radiation at patients at the surgery unit, and so we often saw this fat necrosis afterwards if the tumor was a little bit near to the skin, and the problems afterwards. And for what the decisions is, once again, the autologous lipotransfer, I think this was acceptable results, but the problem is, in my personal opinion, you do it more than once a time if you have such a maybe cosmesis problem because of the fat necrosis of the intraoperative radiation therapy. I think if this maybe brachytherapy and so on, it's coming more and more. I think these problems would come to our clinics again, that we have to deal with these problems with radiation afterwards. And then we have to think again, do we need maybe implants? Do we use flaps? Do we use maybe lipotransfer, because we have only one part of the breast is involved in these problems? So I think this is a new topic, but it's coming in the future. Many thanks for your attention.
Thank you very much for this excellent presentation. And I don't know if there are no questions from the participants, who, by the way, are still 160 from what I can see. So any comments from anybody from the panel?
A very interesting one, actually, because I think I've made the same observations about fat graft. Actually, usually after radiotherapy, after the first sitting, we don't find that much of a volume change, but the whole area softens. And the patients do say that they get a lot of discomfort going away, because I don't know whether we break the scars or the fat does something. Usually it needs, a post-radiotherapy needs at least a couple of sittings, at least 3 sittings. Sort of thing.
Yeah, this is the problem of this method, in my personal opinion. Yeah.
Can I ask a question? Do you have any experience, or do you know what happened with titanium meshes when they got irradiated?
For me, the question?
Yes.
Maybe the trial for that one, to analyze it in the original trial, is running. So my personal opinion, I don't know. I don't know if the capsular fibrosis is less, but maybe we have now 30 or 40 cases. So 11 or 12 are radiated. So I think if it's one or more, two, I don't know if it's, maybe the trial will answer it. But for me, no, I can't say. Probably we get less capsular fibrosis until now.
Less? You think it's less?
I can't. No, I can't say it.
Okay.
I can't say it. Maybe we can't. In my personal opinion, we can't go out with this message because we don't have the data for that.
Okay. So if you have a high suspicion for giving radiotherapy, you wouldn't go for that mesh. You would go for something else, either.
No. No, this is for all of them. So I love to use this meshes if I have big pockets, because yeah, you see a good retraction of the skin, you have no rotation problems and so on. So, but if this is for me a little bit, for a lot of papers and RCTs, I love to say is it's proven in an RCT to say we have less capsular fibrosis in case of radiotherapy if you use titanium pocket, yes or no. I think this only could be answered with a randomized situation, and only could be answered with this as an endpoint. What I learned in all the trials, if you can answer the endpoints correctly, because the CIFs and all the questions are going to the endpoints, and then you get it. So because all is driven by the endpoints, but if we don't have this trial, we can't answer it sufficiently, in my personal opinion.
Thank you very much. There is one question from the audience. It says that implant as placeholder for patients that will have postoperative radiotherapy. Do you place it prepectoral or retropectoral, subpectoral?
Since in our clinic, since 4 years prepectoral, or nearly always.
And obviously with that 40% complication rate.
No, this is what we're talking about. We have to talk in Germany because of the law about the complication rate. You have to fix it, you write it, and so, and we look at the literature and look at the strongest situation, and then we write down the maximum complication rate is for the capsular contracture is 40% if the radiation is coming afterwards. We don't see 40%, but we talk with the patients about the strong effects because of the law.
Okay.
And
Corina.
So if there are no more questions, are there any more questions? Dr. Adamopoulos, you had a question from the last section.
Yeah, I had an important comment of using large implants. What is very helpful is during after we finish the mastectomy, we use an ICG camera in putting the patient in the sitting position and put inside a sizer. We keep the sizer for 15 minutes. So using the ICG camera, we can evaluate how the blood supply and the venous are involved in any ischemia. This is one trick that I don't know, just saying. And on the other side, what does it mean large implant? The large implant is a weight implant. It is a very heavy. So I use personally, I've used the 550 cc implants without any problems. But this is very individualized. It's not general. We must be concerned just about the blood supply with the flaps. This is the first. And on the other thing is on the DTI technique and the implant-based reconstruction. My dogma is the best chance is the first chance. So the first surgery must be very precise. Thank you.
Thank you very much. So I think we've come to an end. Thank you very much for the presentation and all the participants. And I think Dr. Venizelos will have to give us a closure statement.
Well, I think it's been a very interesting afternoon. I would like to thank everybody. I would like to thank Professor Kümmel for his special effort to give us 5 talks. I would like to thank Dr. Simyan. He's been with us all 5 hours now. I would like to thank Professor Gülüoğlu from Turkey. I would like to thank everybody, all the speakers, moderators, Dr. Lanitis, Professor Kondos, all the participants, and I hope to see you back in Greece next year. Thank you very much indeed for your help. Thank you.
Thank you very much.
Thank you. It was a pleasure.
Bye-bye.
Thank you.